Hey, Rudy. Thanks so much for coming all the way from Miami to Dubai. We're very happy to have you here. We have worked together in Miami before, and I'm so happy that you're visiting Dubai and we're able to do this podcast together. We're going to talk a lot about men's health issues today, and I'm very happy that we are going to have this conversation about issues pertaining to men, especially younger men that face them today. We're going to cover a wide range of topics, all the way from testosterone levels, sperm counts, obesity, insulin resistance, GLP-1 agonists, what's good, what's bad about them. We're going to touch upon a little bit about endocrine disruptors, microplastics, and how environmental factors can affect all of the things that are affecting men these days. So we'll get started. Very happy to be here, and thank you for joining us.
Such a pleasure. I've been looking forward to this. You know, we worked in Miami together.
Yes.
We actually did a podcast together and talking about this. Again, you know, I went to University of Miami for my med school. My practice is very far to UM, so we referred a lot of our patients to you. So it's a pleasure and an honor for me to be here today, and I'm excited about these subjects.
So what do you think are like the primary issues facing young men, and specifically adolescents and youthful men these days? Like what are some of the most important crises or factors that young men should be thinking about as they're growing up?
So many, but we're going to focus today again on the low testosterone epidemic that we're seeing at our practice. So, you know, I'm internal medicine, so I didn't get trained on how to replace testosterone, because when I went to medical school in the 90s, the only hypogonadism that was recognized was late onset hypogonadism, meaning that guys will get hypogonadism, low T, in their later years, their 60s and 70s, unless they had things like testicular cancer, radiation, mumps, arthritis. So when I started doing my practice, so I got a board certification with the age management medical group to really learn how to do testosterone replacement. Again, didn't learn it in medical school. So that was since 2005. Beginning of my practice, most guys that I saw who needed testosterone were in their late 50s and 60s. Then all of a sudden, I started seeing younger and younger patients in their 30s, even in their 20s, coming with real symptoms of low T, real symptoms of hypogonadism. And I was like, what's going on? I know they weren't seeking drugs. They weren't, quote unquote, juicing. And I was like, but they had real symptoms. And most of them were coming to me after they've done everything already. They took the supplements, they lost weight, they tried to exercise, still had low T. And I'm going to tell you, Ranjith, the paper that you produced, you and Lokeshwar, that showed that adolescents and young adult men had a 20% incidence of hypogonadism, and that their low T symptoms started when the testosterone is in the 400. That was practice changing for me, because it gave me a scientific leg to be able to justify why I was seeing those patients.
Absolutely. I mean, and one of the nice things that we did in that study was to try to see why this epidemic was happening. Why did the testosterone levels decline between 1999 and 2015? You know, this is 15 years. It's a very short span of time. And we saw about a 20% decline in testosterone levels in the men between 15 and 39. And one of the interesting things that we saw was the BMI had gone up during this time. Levels of obesity had gone up, especially in adolescents and young men. And I think, unfortunately, the COVID pandemic didn't help much to this process either, where I think activity was asked to be reduced, physical activity, physical interactions were asked to be reduced, and men sort of, both men and women were asked to be secluded, would have less physical activity. And if anything, I think this trend is going to continue unless we as a society make a difference to be more physically active, to eat healthier, and to think about not leading a sedentary lifestyle.
So we're definitely going to touch on this, how obesity and insulin resistance plays a role in testosterone deficiency. But something that was interesting in your paper, and correct me if I'm wrong, is that even when you corrected for obesity, the trend was still statistically significant. So again, that was another aha moment for me, right? Because a lot of times we'll see guys with testosterone deficiency. And they're like, it's because they're overweight. It's because they're not exercising. it did not hold up every time.
Right.
So your paper again showed me that yes, obesity plays a role, but it may still happen when it's not there.
That's correct.
And that's when I also interviewed Dr. Shanna Swan, the epidemiologist from California, who discovered that there's been a 52% decline in sperm count over the 40 years. And she was able to link that directly to plastics, phthalates, called the phthalate syndrome. So now I looked at it, and you look at the curve of the production of plastic, and now 100% of humans that we check have microplastics in their blood.
That's correct.
100%. So Dr. Swan was able to put a direct link between phthalates and infertility. Between phthalates, even when the baby was exposed in utero, no fault of their own. They had a shorter anogenital distance. They had testicular dysgenesis syndrome that then correlated to lower sperm count and to testosterone deficiency. So between your study and Dr. Shanna Swan's study, that was the aha moment for me. So we'll see an increase in obesity that may translate in increase in testosterone deficiency, but there is a silent driver, which is the microplastics that we'll find in 100% of our patients.
Absolutely. I think both environmental factors like endocrine disruptors, pollution that we are exposed to either knowingly or unknowingly, as well as factors such as obesity, sedentary lifestyle. I think all of this is a combination, which is why I think we're seeing a decline in testosterone levels and a decline in sperm counts. And you're absolutely right. I think male fertility specialist, as a reproductive urologist, I mean, we see this day in and day out of people with young men who have very low sperm count or even azoospermia that is unexplained. Usually in the past we used to be able to attribute this to some genetic factors. You mentioned about mumps, orchitis, cryptorchidism, undescended testes, genetic factors. But now this bucket of men who fall under unexplained infertility, unexplained azoospermia, I don't think it's really unexplained. I think we discussed some of the causes today already about why this is. We just can't pinpoint to one specific factor, and so we put them into this bucket of unexplained low sperm count. But I'm fairly certain this problem is only going to continue unless as a society we take some correctable actions.
Yeah. Well, what's sad, and we're going to do the rabbit hole of microplastics and endocrine disrupting exposure. I saw a study where 100% of the testicular tissue that they looked at had microplastics in them. And microplastics carry phthalates, and who else knows what? There's a concept called the exposome. The exposome is everything that you've been exposed to from the time that you were in the womb until now. We're exposed to thousands of chemicals on a regular basis. Most of them have endocrine dysfunction. Most of them have reproductive action.
Yeah.
So who knows what has caused what's happening now? So what I usually will tell my patients, and I had a patient exactly like this the other day, 32 years old, complaining of the typical symptoms of low T, tired, no motivation, which is a big one, low libido, getting more belly fat, losing weight, losing interest in a lot of those things. Went to see many of his doctors. They told him it was normal. His testosterone was about 350, right? For listeners, normal is 300 to 1200. And they told him it's not testosterone. They told him you are stressed, take a vacation, try to meditate, all those things. Came to me, I checked his total testosterone, his free testosterone, and his SHBG. His HBG was really high, meaning that it really binds a lot of his testosterone, and his free testosterone was low. So there I was able to diagnose him with testosterone deficiency with a low free T. Started him on treatment, and he thrived. He did amazing. And this guy was a lawyer, a corporate lawyer, that was working hard, had 2 kids. He told me and my wife are basically roommates now, right? No libido. Testosterone replacement completely changed his life. It increased his vitality, his motivation. He was able to finally quit his corporate law job and open his own law firm. And he said, me and my wife are dating again. I'm having a life again. So I'm looking at the trajectory of this young man. And I've seen so many of those. They go see different doctors. The doctors are unfortunately so stuck into a number. If you're not below 300, and now for endocrinologists, below 264, you will not get a diagnosis of hypogonadism. So this is so full circle for me. And again, your paper has helped me so much with this, to realize that when it comes to hormones, it should not be a number diagnosis. It should be a clinical diagnosis, and the numbers help you.
Right.
But our patients are suffering. We need to look at things differently and really help them.
Absolutely. I always also try to see what the delta is, the change in testosterone. So some patients have more than one testosterone level. And if you have dropped from a level of, let's say, 650 last year, and now you're about 400, according to the guidelines that you mentioned, you're still well within the normal range. But that patient who has gone from 650 last year to 400, for whatever reasons, his circadian rhythm has changed. He's not sleeping well. He's gained weight. He's developed new onset sleep apnea. Whatever reason, I think we should absolutely correct the underlying reason. I'm not opposed to identifying and correcting it, but I think we should also help him with the symptoms. Because I don't think we should just say, oh, your 400 level is normal and not treat it at all. I am all for trying to encourage treatment to try to improve while correcting the underlying problem.
Yeah, so we do that a lot at the practice. We go with clinical symptoms. Of course, we always tell our patients, make sure you cover the pillars of health. Good nutrition, exercise, especially resistance training, sleep.
Right.
Make sure you cover those. But if those are covered and you're still not feeling well and your numbers are at the lower quartile, it may be worth doing a therapeutic trial of testosterone.
Right.
I'll do a 3-month trial
Right.
and I have the patient come back. How do you feel? If you've had improvement in your symptoms, I've proved what happened to you. So, you know, endocrinology used to be a specialty that was symptom-based. Now it became a numbers-based. So I think it is a travesty. And, you know, for me, being the internal medicine guy, the functional medicine, the biohacking MD, we're going to talk about biohacking, to see that a urologist like you know, like a professor, an eminent urologist, now understands that symptoms also matter.
Absolutely. So there's a lot of talk about GLP-1 agonists. You know, there's about 10 available GLP-1 agonists in the market. It is actually now approved for adolescent obesity in the United States. Some patients who take it swear by it. They say this is the best thing ever. Some patients say we are scared to take it because we are scared that we may be on it for the rest of our life. Can you educate us about, you know, the good and the bad? I know you're writing a book on, you know, GLP-1 agonists, but just tell the audience about what is good, what is bad, what should people watch out for, and is dependence on GLP-1 agonists a real phenomenon, or can people come off of it safely and still lead a normal life?
Do you have 5 hours? Because that's my favorite subject. Okay. My favorite subject. So although I love testosterone replacement therapy, GLP-1 is what I am completely passionate about. So again, for listeners listening, GLP-1 is glucagon-like peptide 1. It is an incretin hormone, meaning that it is a hormone that's secreted by the gut, usually helps with insulin and removing of blood sugar, disposal of blood sugar. So what was interesting is that they discovered that in the Gila monster, that's a lizard, they found very high concentration of GLP-1. And they were doing studies from the 1980s. And finally, in 2005, the first GLP-1 was FDA approved for diabetes. So it's 20 years that we've been using those GLP-1. I've been using them on my patients for about 19 years. Okay. So basically what GLP-1s do, they help improve insulin resistance, help improve diabetes because it increases your insulin release. But it has other things. It helps decrease your hunger. It's really good with this because it decreases gastric emptying, slows down your digestion, so you stay full longer. So the first generation of GLP-1 weren't that good for weight loss. Until 2014, the first one was FDA approved for weight loss, liraglutide. I used it quite a lot. It wasn't great. People were losing maybe 10 to 15 pounds. Then in 2018, semaglutide, Ozempic came onto the market. And that was the miracle. With that medication, people were able to lose 15% of their body weight usually. Kim Kardashian actually talked about it at the Oscars. It became a cultural phenomenon because people were able to lose weight significantly. Then in 2021, Mount Jao, the latest one, tirzepatide came on, which was a dual agonist, GLP-1 and GIP. And the results on this are even better. So First, I want to say that it's been 20 years of clinical experience, because a lot of people, even doctors, will say, oh yeah, it's good, but we don't know what's going to happen.
Data. Yeah.
20 years, that's a lot of data, millions of people taking it. And the problem that we're having in our society, more than the testosterone issue, we have an obesity and metabolic disease epidemic.
Absolutely.
So the latest pandemic,
yes.
completely. The latest numbers that show they define another syndrome called the cardio-kidney metabolic syndrome, CKM. 93% of Americans had at least one of the components, meaning that only 7% of Americans are metabolically active. It's crazy when you think about those numbers. About 70% or more of Americans are either overweight or obese, have increased inflammation with visceral fat. So it's an epidemic that is fueling the crisis of cardiovascular disease, kidney disease, even Alzheimer's dementia that we now call type 3 diabetes. So when we've been confronted with such an epidemic, I've had my weight loss clinic, coincidentally enough, since 2005. So what did I used to use for my patients for weight loss before? Nutrition, eat less, move more, avoid sugar. You tell them that, right? What I had back then, I had the stimulant type medication, the phentermine, diethylpropion. They weren't great. They were FDA approved, but that's what I used. The emergence of semaglutide, Ozempic in 2018 was a complete paradigm shift in the treatment of obesity. Why? Because, again, it was interesting that the previous GLP-1s weren't that good for weight loss. I think with Ozempic, because it was able to cross the blood-brain barrier, and we have a lot of GLP-1 receptors in the brain, and it created an appetite control that we've never seen. Actually, patients described that the food noise is gone. Food noise, that's a term that was only invented because of GLP-1. And my patients would tell me all the time, I'm like, explain what it does for me. They're like, Doc, I wake up in the morning, all I think about is food. I want pizza, I should have ice cream, I can't believe I had the ice cream last night, what do I want for lunch? It's food, food, food. And usually patients will take GLP-1, usually within 1 or 2 months, not everybody, but I'll see maybe 75 to 80% of the patients have this. It's quiet, quiet. The food noise is gone. They're able to make better choices. Everything that me and you have been telling them, everything that they know they should have done, now they're able to do this. And that's when I realized the obesity of epidemic that we're seeing, it's not a question of willpower. It's a neurobiological dysfunction that happens in the brain. It is a hormonal imbalance. GLP-1 is for satiety. So it treats food addiction. Because what's fueling the epidemic? It's our addiction to sugar. Sugar. And I'm here now in Dubai, and I'm seeing the amount of sugar that people are eating. They're drinking sodas like crazy. It's almost like the American diet is being exported to all of the world, including the Arab world. So GLP-1s have been a complete paradigm shift when it comes to treating obesity, because it treats the root cause of food addiction, sugar addiction.
So do you think people can come off of it?
So that's a very interesting question. So again, I have thousands of patients actively on GLP-1 medication. So first, I don't think patients should qualify, quote unquote, to be on GLP-1. I hear that all the time, right? Because in the studies, it showed it was patients who had a BMI of 30 or over, or a BMI of 27, plus some kind of disease like diabetes, high cholesterol. I'm not like this. If you're somebody who needs to lose weight and you've been trying, yes, I'm going to try GLP-1 on you, because I want you to lose weight. Because I have patients who have, like, let's say, 10 pounds of weight to lose, but it's all in the belly, all visceral adipose tissue that causes inflammation. We need to get rid of this. So the way it usually works at my clinic, when a patient comes in, I go over their medical history, I go over what do you think their issue is with food. Most of them, it's food addiction. They don't like to say food addiction, but it is food addiction, right? And then we start the program. Start GLP-1 medication, usually by 2 months, 3 months. Their food noise is gone. They're eating better. Most doctors send me their non-compliant patients, right? The patients that they've been saying, eat less, they can do it. I change their lives.
Got it.
By 4 months, most of my patients lose 20 pounds, 30 pounds. Usually 6 months, then we have patients lose 60 pounds, 80 pounds. I have more than 20 patients who lost 100 pounds. So those are life-transforming stories. The big question, as you said, is what happens after. And there's been some studies that show that when you stop the medication, people within a year will gain about 50% of their weight back. There's a couple of ways I look at this. Number one, if you regain 50% of your weight back, you still negative 50%. So that's still, it wasn't a failure. You still did something. Number two, we need to start considering that chronic obesity may be a chronic disease for a lot of people, right? So there's some patients, as soon as I stop the GLP-1 medication, all their bad habits are back. Their food noise is back. Their cravings are back. So somebody like this needs to stay on the medication on the longer term, not because they're weak, because they have the neural circuitry that keeps them addicted to food.
Got it.
And my patients usually find 3 different buckets when they finish with their weight loss. I have one bucket, that's about 15 to 20% of my patients, that they use GLP-1 for 3 months, 4 months, 6 months. They lose the weight, they're exercising, they gain lean muscle mass. That cohort of patients never needs to use them again. It's not a lot. But you'll see all they needed, that little push. Now they've changed their habits, they're exercising. Building muscle mass is the best predictor of keeping your weight off.
Got it.
That's about 20%. I have on the other spectrum, maybe another 20%. Those are the patients that after they lose their weight, if I try to stop the GLP-1, within 3 to 4 weeks, they gain 10 pounds, they start eating bad again. That's full food addiction. What I tell those patients, don't be ashamed. It's not your fault. If you're like this, we may have to keep you on GLP-1 for the longer term. And I find a maintenance. Majority of my patients fall in between. They'll come in, lose the weight, use the GLP-1. I take them off of it, try to give them good long-term habits, still have them come to the office on a regular basis for accountability. And those patients will tell me maybe once or twice a year, they need a little boost of GLP-1.
Got it.
They go on a vacation, they started eating bad, they gained 10 pounds, they need it.
Got it.
Stress at work was killing them, they start eating bad. And I tell them, remove the shame. I think that's an important concept. There's a lot of shame for patients using that medication because people tell them you're quote unquote cheating, right? So I empower them. I'm like, you gain 10 pounds over your lower weight, come back here. Use it for a month or 2, reset your mind, reset your habits. Let's set you up for long-term success.
Got it. No, that's very interesting because I think what you talk about is almost, it can be used initially on a chronic basis where you lose whatever goal you want to achieve, but then it sounds like you can be using it intermittently, on and off, and you will still lose it and lose the weight and it'll still be effective. I think patients get concerned that if you use it for a long time, your receptors will get, tachyphylaxis and the drug may not work long term, but it's nice to hear that you can not only stop it, but also take it again and it will still work. May not as well as it did the first time around, but certainly to achieve your goal the next time around.
Achieve the goal. And I tell my patients, the GLP-1 is not what's going to do the work. It's going to quiet the food noise, and then you're going to do the good habits. So I do a lot of behavior modification in my clinic. We encourage them. We help them. We push them to lift weights. When you build lean muscle mass, lean muscle mass is the biggest recipient for sugar. So if you work out, you're able to do that better. So there's a lot of components to it, but I empower patients. Don't be ashamed. Sometimes the patient will come back 6 months later, the walk of shame. They're like, oh, doc, I gained 15 pounds. I'm so sorry. I'm like, don't be sorry. The cards are stacked against you to gain weight. Our food is toxic. They call the American diet, the standard American diet, SAD. It is a sad diet. And I call the SAD diet a weapon of mass destruction because that diet is causing hundreds of thousands of deaths. Cardiovascular disease remains the #1 killer. Diabetes, neurocognitive dysfunction like Alzheimer's, dementia, all of it or most of it can be tied back to our addiction to sugar. That's fueling the obesity epidemic. That's then fueling those chronic diseases.
And it's also fueling lots of other chronic diseases like Alzheimer's disease. Many of the cancers are associated with underlying obesity. Obesity remains an independent risk factor for just about every disease that we can
Almost
think
every
about.
Disease. And to go further into the root cause, what causes obesity? It's sugar. In most cases, bad eating, right? Processed foods, bad eating.
Right.
But the sugar, overconsumption is out of this world. And I don't know if you remember, you're younger than me, so you may not. Back in the late 1990s, there was a Time cover magazine showing a rat that they put in front of him, sugar or cocaine. The rat kept going for the sugar, not for the cocaine. So sugar is more addictive to cocaine. So that's a strong statement to say, but what it is that sugar really lights up the dopamine rewards pathways a lot more. It's not as dramatic as cocaine addiction, but that sugar addiction is a slow killer. And it's harder for a patient to quit sugar than to quit cocaine.
Yeah.
How crazy is this?
I mean, we've spoken enough about testosterone therapy and GLP-1, and it sounds like there are lots of similarities between the two in terms of, trying out for 3 months, staying on it for long term, not feeling ashamed about it,
Yes.
Trying to regain your confidence by losing the weight, gaining muscle mass. What is longevity? There's lots of, I'm sure now coming to Dubai, you've seen lots of longevity clinics. Lots of physicians are, some are actually specialized, some are claiming to be longevity physicians. What is longevity medicine? This is not something that was there when I was in medical school, certainly not there when you were in medical school. Is this a specialty? Is this something? Explain that. So when should a patient go and see a longevity physician, or should we even wait to become a patient, to have illnesses to go see a longevity physician? Or is this or are we just trapping people into coming to see doctors when they don't necessarily have to?
So I consider myself a wellness and longevity physician. I'm a primary care doctor, internal medicine. First, I started my practice as a hospitalist. I was working in the hospital, ICU, emergency room, dealing with life and death situation, acute medicine. And Western medicine is really good at acute medicine. We're not good at preventive medicine. And worse, we're not good at what I call optimization medicine. And that's what longevity and wellness medicine is. So, the functional medicine world has always been obsessed with lifespan. How do we increase people's life? But lately, and which is the great thing, the new term is health span. How many years that you're going to live that are healthy. And that's what's important, because I'm also the medical director of a nursing home in Miami. And I have patients who are there 65, 68, in their 70s. They're in a nursing home. They can barely move. They have dementia. They have loss of memory. They lost their independence. Do we want to live long if that's how we're going to live? So to me, the longevity movement really embraces the concept of health span. How many healthy years you're going to have.
Right.
And for maybe a 20 or 30-year-old person, that may not ring anything, because at that time you think you're invincible. I'm 55 now. I'm looking at the second half of my life. I'm seeing first what hormones have, my decline of hormones has done to me. And I'm like, wow, this is what getting old is like. Where am I going to be the next 20 to 30 years? So longevity medicine is, again, no longer just increasing the number of years that you're going to live. It's increasing the number of healthy years that you're going to live. And what I love with longevity medicine is that it goes back to basics. And I was lucky because my undergrad major was in nutrition. So I've always been pushed to talk to my patients about what they eat. Longevity medicine is big on this. Again, they go over the pillars of health. Good nutrition, movement and exercise, and focus on sleep. Then the focus on what supplements you should take, because unfortunately, our toxic diet and the way agriculture is happening now, even if you try to eat healthy and try organic, you don't get a lot of the micronutrients and electrolytes that your body needs. So you may need to supplement. So exactly what you said. Are we trapping a lot of patients in this world? If we are, it's a good thing. Because patients who usually come and see doctors like me in wellness and longevity, they're highly motivated. They're not coming there because they're sick. They're coming there because they're like, Doc, I want to feel my best. I want to be my best. And then we can give them the right tools to be able to go there.
Right.
And with the development of AI and everything that's happening, we are going to be able to extend lifespan very soon.
Or health span.
Exactly. Lifespan, so the patients who see wellness and longevity doctors will be able to help increase their health
span. Got it. So you think it's just very, what age would you think that people, and now I'm calling people, I'm not calling them patients,
Very
because
good.
people who are well, who are, what age should they be thinking about, quote, optimizing their health?
Yeah.
Is this at 20? Is this at 30? Is it at 40? Is it at 50?
Yeah.
When should they be checking their blood tests, checking their cardiometabolic risk? When should they be doing this? And then obviously, if anything is abnormal, they should seek help. But if everything comes back normal, do you think they should still go down this path of trying to see if they can optimize this even better?
Yeah. So again, now we're going to talk about the concept of biohacking. And biohacking should be done at any age. So what is biohacking? Biology hacking. So it is basically looking for a cheat code to improve your biology. Everybody should do this. And biohacking is simple. If you drink coffee in the morning, it's a biohack, because coffee increases your energy. So you found something that improves your biology. If you take creatine, if you work out, that's a biohack, because you increase your muscle mass, that decreases inflammation and helps your biology. So anything you can do to have your physiology work better is a biohack. And the earlier you start, the better, because we've almost normalized bad habits in our society, right? When I eat healthy, people ask me, oh, you on a diet? How come you're only eating a salad? Here in Dubai and in Saudi Arabia, where I was, I don't drink soda anymore. I drink water. So everywhere I go, they're like, what do you want to drink? So I'm like, water. They're like, no, we have soda, we have this. So we've normalized eating those bad foods, and drinking water instead of soda, it's a biohack, because I'm helping my biology. So the earlier, the better. But at the same time, I don't want to medicalize this, right? Right now on TikTok, there's a trend that young men are using steroids, trenbolone, to gain more muscle mass. I'm against that, right? I don't want to medicalize it. But the earlier somebody can say, okay, let me see what I can do to improve my health, to improve my biology, by any means necessary. Sleeping better, eating better, exercising, trying to get the right supplements, mindfulness, taking time to slow down. All of those things are biohacking. And then another thing I want to say, you had said that before, I encourage all of my young men to check a baseline testosterone level, because as you were saying, it's the delta, the change in testosterone, that's important. So let's say I have a 22-year-old man who's like, I want to check my testosterone. I'm like, yes, do it. Most likely, and I'm hoping, although we've seen 22-year-old men with low T, but my hope is that you don't have it, but maybe you get a baseline so that by the time you're 30 or 40 and you have symptoms, we can see what the change in testosterone was.
Right. No, I think it's very important. And I also, coming back to, talking about Dr. Swan's work about sperm counts, we at a time in society where we need to be screening for male fertility? Do we need to be screening for low testosterone? And I think given all of the data that we have so far, I think we are at that point where I think if a man that turns 18 or 21, I think getting a sperm count and getting a serum testosterone level, I think is completely reasonable. If both of them, like you said, was normal, I think there's less to worry and we'll have a baseline. If those were abnormal, let's say the sperm count was very low, and in some rare cases, 1% of men will have zero sperm count, I think the sooner action you take, the better off you're going to be. Because we have sperm freezing capabilities that can preserve your fertility for the future if the sperm count is very low. If your testosterone level is very low, you can identify hopefully an underlying cause for the low testosterone, be it a modifiable risk factor, sometimes a non-modifiable risk factor. But I think trying to take action on your health, the earlier you do it, I think is going to be better. You mentioned a little bit about supplements. There's a lot of talk about micronutrients, calorie counting, weigh the food that you eat. It seems overwhelming, to some point, because if you open TikTok and if you open Instagram Reels, I mean, this is all you're seeing. It's like people are advocating for one or the other. And sometimes, and I go back to this, people who are well and healthy don't know which path to take and which path to follow. How would you digest all of this information for like a young, healthy 25-year-old guy?
That's a tough one. And I'm even like guilty of this, right? Because I've done the rabbit hole of supplements, of testing. I test every biomarker. I've taken all of the supplements. And you can get, if you watch TikTok, then your algorithm, that's what all it's giving you.
Right.
Take this supplement, this diet. So like everything in life, it's finding the right balance. It's not right to say people should not do this, because they should care about their health.
Right.
And just try to think about the way medicine was for our parents, right? Our parents would go to the doctor, barely ask any question, be like, doctor, tell me what to do. I don't need this medication, or I'm good. Okay, see you next year. No participation from themselves. This is changing considerably. And I credit social media, and I credit the biohacking world, because now patients want to be better, right? Influencers. I used to I don't like influencers, but now I do. You know why? Because they have more followers than you and me.
Right.
And they bring consciousness, awareness to a lot of those issues, that you need to eat better, you need to do this. So at least I say, everybody, try to prioritize those three things, the pillars we always say. Eat better, exercise, and prioritize your sleep. Don't get too caught up into the details. At the end of the day, nutrition is simple, right? Don't eat too much. Eat a lot of plants, not just animal protein.
Right.
And make sure that you try to eat whole foods, not processed foods. If you stick with basic simples like this, forget all of the crazy diets. And I'm not against people trying, let me try the carnivore diet for a short time, the keto diet, try the whatever diet. But at the end of the day, you would go back into something closer to a Mediterranean diet, a clean keto diet, lower carbs, lower sugar, and make it go like this. So yes, I like that patients are being proactive and made aware by the influencers, but that's when we as physicians, we need to be able to clear the noise from them. And the other thing that I see a lot, it's information overload. It's actually, there's a term for it. It's called orthorexia. Orthorexia, it is when biohackers or people are just obsessed with taking the next supplements, obsessed in doing the next cold plunge, a red light. They're taking all the supplements, and they're consumed by the idea of getting optimized. Well, everything that you consumed is not good. So I talk to my patients about this. I'm like, because when you do this, you increase your cortisol levels, you increase your stress levels. So, but I don't want to at the same time make it go all the way to the other side. Like it's a pendulum. Right now I have a lot of patients who are too much into biohacking. They're obsessed with it. And what I tell them, always find a way to balance that obsession with just being.
Right.
With just learning how to do. And that's why big time mindfulness meditation, learning how to just be okay with this. There's a Chinese principle I like a lot. It's called Wu Wei, W-U-W-E-I. That's the art of non-doing. The art of non-doing. So I try to teach my type A biohackers, crazy, who want to do everything. They track everything, right? Even when they meditate, they're like, let me check how much did my HRV go down. They track their sleep. Creates anxiety.
Right.
I'm like, yes, keep doing this. I applaud you.
Yeah.
But embrace the art of non-doing.
Right.
Embrace Wu Wei. Just flow with it. Just let things happen.
Right.
Manage your anxiety. It's really hard for people, especially Westerners. Western mind is either or. It's either I'm a biohacker, I'm going full force, I'm doing 100%, or I'm a complete lazy bum and I do nothing. Finding the balance between those. Yes, research, do all of this, do the biohacking,
Right.
but take time for mindful resting and effortless action.
Absolutely. I think that's probably the theme of the podcast, right? Everything in balance, everything in moderation, I think is probably the most important. You touched upon Trenbolone and TikTok, and we do know, we've talked about testosterone therapy and young men with low testosterone, but we do know from our practices that majority of now patients or people who receive testosterone therapy are not from doctors, are not from pharmaceutical grade testosterone and or steroids. And there is a huge fad into trying to look good, especially now with social media that has influenced this. It's like, we need the six pack, we need the muscles, we need the biceps, we need to. It's all need to, not want to. It's need to, and because we live in this Instagram generation and Insta generation of everything needs to happen tomorrow, I am not going to put in my 12 months, 18 months of workout time to get there. I am going to do it in 3 to 4 months, and so people resort to, let me get this from my friend, let me get these steroids from my friend, from my coach, from my trainer. And we see a lot of adverse effects from
Lots.
that. I see obviously azoospermia. You must see a lot of steroid withdrawal and suicidality and depression that can happen when they actually come off of all of these steroids. How do we, as a medical society, do you think, try to encourage this movement away from the gym, away from the trainers, and back into the medical field? So now these people who have become patients can get monitored safely and can be advised of what is good, what is bad, what are the long term, and even if they're coming off of steroids, to do it in a proper way.
Yeah, that you touched on something that's so important. And like I said, influencers actually like influencers because they have so much influence on the public that they raise awareness. But it goes too far. And a lot of them have really no credentials and give bad advice. And for the person listening to this, how do they differentiate what's good advice, what's bad advice?
Right.
So I'm advocating for the rise of the MD influencer. You an MD influencer. I'm an MD influencer. We're influencers that actually have clinical expertise. We have the background. We can talk about this. But what happened, usually us physicians, academics, we don't like to do this. We don't like to show and go on TV and have followers, right? So that's why the people who are listening don't see us. They see the others. So what we're doing here, Ranjith, I think it's so important. Me and you need bigger platforms. Doctors like us need bigger platforms. So we can become MD influencers, because at the end of the day, we have the patient's, the person's best interest in mind. So we'll have the credentials. So and it's slowly starting. I'm seeing more MDs starting to talk about this. But the way we're going to fight this is not by talking bad about the influencers. It is by becoming as famous as them. It is by becoming as big on a stage as them. I love doing this not because I want fame, because at the end of the day, we're healers, we're teachers, we're educators. If our sphere remains small, we haven't touched the world, right? The world is a global village now. Internet makes it that we go everywhere.
Right.
People like me and you, MDs like me and you, who have the clinical experience and the background and the training for this, need to become those MD influencers so that people can look at us and be like, I trust what this guy is saying. But that said, our society likes the quick fix, right? If we're going to tell them, eat better and exercise 12 months,
Sleep
they may not
better.
know, listen to us. But there's a way to balance that. And recognizing that really a lot of people who are looking for help do have a victim of our toxic world. This is no longer the world of 30, 40 years ago where people didn't have as much disease. We need to recognize that, make sure that we test and have a lot of empathy and compassion, especially when it comes to endocrine disease. And then when you see them, there's options that you can do. Let's say somebody comes with symptoms of low T, and then we'll talk about this after. The clomid of this world, the HCG, what can we do for somebody who comes in with real symptoms? How can we help them? Right? And my question is for you now. And I know you've had talks about this, right? Let's say you have a young man in his 20s or late 20s, early 30s, comes in with symptoms of testosterone deficiency. You find him with low testosterone and you decide, I see a lot of providers like to do clomid. Tell me about this.
So clomid is an estrogen receptor modulator, and because it is very similar to estrogen, that's the only way it can bind to the estrogen receptor in the brain and increase your own natural production of LH and FSH that can stimulate your own testosterone production. I like clomid. I prescribe clomid for men who I think are trying to actively achieve fertility. So are trying to improve their sperm counts, who are trying to naturally improve their testosterone levels. I think clomiphene is a very good drug. However, in the long term, I don't know if clomid is such a great drug because it's an estrogen molecule, and it comes with its own side effects of gynecomastia, weight gain, fluid retention, hypertension. And so erectile dysfunction and low libido, because now you're blocking the estrogen receptors, which we know are critical for libido even in men. And so as a drug for fertility and to improve sperm counts, I think it's fantastic. But in a young man who wants to improve his testosterone levels, I think absolutely we should think about naturally improving their own testosterone levels, or trying to do a short course of testosterone therapy like you talked about, trying to boost their energy levels, trying to boost their exercise regimen, trying to get their weight loss going by either in combination with GLP-1 agonists or not. and then trying to see if we can come off of testosterone therapy, I think would be a much better regimen in this young guy with low testosterone, as opposed to putting him on clomiphene citrate and facing all of the side effects that can potentially happen in 3-6 months down the line.
Exactly. And that's why the expert, I love talking to you. And, I use clomid exactly for this. Short term, especially if they desire fertility. I tend to use N-clomiphene also, which I'm getting better results with. But at the end of the day, you see, sometimes I have patients who come on clomid or N-clomiphene, and we'll see their testosterone levels go up, but they don't have clinical improvement
in symptoms.
They'll
Correct.
have sperm numbers improvement. So that's a thing. And something you said very important, and I see that in the clinic, and there's actually now studies showing that. There are retrospective studies showing that GLP-1 medications, when you use it on men, they lose weight, they lose belly fat, their testosterone levels go up. And then the other thing I want us to touch about is now the advancement that we have oral testosterone, like oral testosterone under cannabis, that does not suppress LH and cause infertility.
Right.
So tell me a little bit about this.
So the concept of testosterone therapy causing infertility is because most testosterone medications that we have in the market are long-acting. And so therefore they suppress LH and FSH production from the brain, leading to azoospermia, meaning no sperm count. About 30% of the patients that use it, and about 60% of the patients can have low sperm counts when using testosterone therapy. So oral testosterone and some of the nasal testosterone gels that were previously available in the States have all embraced this phenomenon of using short-acting medications with testosterone. And so as long as they are short-acting, they don't have continuous suppression of the brain hormones.
Yeah.
And I think because of their short-acting phenomenon, they unfortunately have to be taken twice a day.
Yeah.
And so their suppression of LH and FSH doesn't happen, and sperm production can be preserved in these men.
Yeah, and I love that we have that available. I have a patient the other day that came exactly like this, 28 years old, classic symptoms of low testosterone, also overweight. Testosterone was in the 310, his free testosterone was low. I put him on GLP-1 medication. I put him on one of the oral testosterone undecanoate because he had no energy to go to the gym. So he was able to lose weight. He gained muscle mass. 6 months later, he was down 60 pounds. He gained muscle mass. I was able to take him off the oral testosterone because it wasn't, because if you put somebody on injectable testosterone, you have to do a post-psychotherapy, HCG, which is kind of a mess. So now that we have this new tool of oral testosterone, I think it's a game changer. And I know you were one of the first ones that did the study on this and showed that it preserved fertility.
Fertility, absolutely.
Yeah, Ranjith, you're just a pioneer in this field. I love talking to you about this.
Got it. So we have 5 minutes left.
Yeah.
Do we need to hit any other topics, or are we okay?
Yeah. No, let's keep going.
We'll do closing arguments.
Yeah, closing arguments.
Okay. What do you want to address, Bashir? Let's ask Bashir what question he wants. What do you, supplements. Okay, we'll hit that with that. Okay, sounds good. Supplements have become a multi-billion-dollar industry. It is only expected to become. It's only expected to grow more in the next, 5 to 10 years, because people have realized, like you mentioned, that all nutrients, micronutrients that we need cannot be obtained from the diet that we are currently having. Maybe 20, 30 years ago, the diet that we had was very different than it is now, and we do need supplements. So what do you think, in your mind, are supplements that people who are healthy, who have done their cardiometabolic risk profile, everything's come back completely normal, but they think they need to take some supplements? What do you think?
For me, my top 5 would be vitamin D3 and K2, because most patients that I check, more than 80% of my patients are vitamin D3 deficient. And vitamin D3 should really called hormone D3 because it has so many effects.
Right.
So vitamin D3 and K2. Magnesium, most patients are deficient in magnesium, and it has so many positive effects and very important. Amino acids, because we tend to be deficient in the amount of protein that we take. And some of the protein may not have all the amino acids. So good amino acids, omega-3s that we usually don't get enough of our diet. So really important. And if I'm dealing with somebody who may have lower levels of testosterone, this is not for everybody, but Tonkat Ali for me has been the best one that I see that if used may give patient an increase in their testosterone.
That's awesome. And I think when it comes into the fertility realm, I think we've actually done studies on this to show that, vitamin C, vitamin E, zinc, selenium, and CoQ10 seem to be the most important for at least male fertility and improving sperm counts. most of the studies, unfortunately, if you go back and look at supplement studies, they've been negative.
Very negative.
And so in the academic community, there's lots of push against routinely giving supplements. But I think the reason they were negative is because all men with infertility were included. I think it's truly specific for those guys who have specific deficiencies in the quality of sperm, not in the quantity of sperm. I think those patients would do much better with this.
Agreed. One last question.
Yeah.
Let's talk about finasteride. Because, now with the online prescribing formula like the HIMSS, the prescription for finasteride has increased by more than 400%. Tell me what you're seeing, because there's so much misinformation about finasteride and the possible side effects.
Absolutely. So finasteride has long been used as a drug for hair loss. It comes in two formulations, the 1 milligram one that is used for hair loss and the 5 milligram pill that is being used for enlarged prostate. There is still lots of controversy about finasteride increasing the risk of prostate cancer, though initial studies showed a positive association. Studies now have showed that there's sort of no association between finasteride and prostate cancer. We see a lot of men with sexual dysfunction. And there is a term called post-finasteride syndrome in men who come off of finasteride, who experience libido impairments and sexual dysfunction long after they've stopped the medication. And we truly think this is because of receptors that block testosterone to DHT conversion, but also because DHT has just been absent from their bodies for a very long time. And this happens both with the 1 milligram dose and the 5 milligram dose. And unfortunately, most of the treatments that we've tried to give back have not worked very well, both by increasing testosterone levels, by giving back DHT supplements, by giving medications that would boost your own endogenous or exogenous testosterone. None of them have actually worked very well. And I think until we actually find a solution, this is a real problem. Men who are going to start finasteride for hair loss have to specifically understand that there is a small but significant percentage of risk of post-finasteride syndrome, and we still don't have a treatment for this.
Yeah, so this is, to me, a big subject, and we call it the pretty boy syndrome. Yes, finasteride works with hair. It will help you grow your hair. You'll look pretty, but you're not going to have great erections. You're not going to have great sperm production. Because as you were saying, it blocks the 5-alpha reductase inhibitor, and then it blocks DHT everywhere. It's really good at this, so you will have more hair. But at the same time, we have so many patients coming to the clinic, and when I go back to when did you start feeling like this? Low libido, some erectile dysfunction, negative thoughts, anxiety, very like suicidal thoughts. It's well described in, if people go and look at postfinasteride pfs.org, they'll see that in Europe, they talk a lot more about it than in the US. So it is not worth it. To me, when a patient takes finasteride, I tell them they're playing Russian roulette with their sexual health, right? They describe that maybe 2% of patients get the side effects. I see it way more. And something that's also very important, what HIMSS did, they pivoted, so they started doing topical finasteride to say that, oh no, it's not as bad. The FDA actually came up with a statement that said that, yes, you can still have things like this. So I see so many young men, they get on that subscription online, they get their health treatment sent to them, 3 months, 6 months, even sometimes up to 3 years, 5 years later, they have symptoms of low T. And they're like, no, doc, it's not it. I'm like, I don't know if it's it, but if you're blocking DHT, that can never be a good thing. And what's amazing now, there's alternatives. I like to use minoxidil. You can do red light therapy for your hair. You can do microneedling with exosomes. So I'm begging anybody listening to this, don't take finasteride for hair. Yes, it works for it, but it's not worth playing Russian roulette.
Risks. All right. Well, thank you very much for coming all the way to Dubai. I'm hoping you have a great time here. And we look forward to staying in touch and collaborating and working together.
Definitely. This was enlightening. Thank you, Ranjith.
Thank you.